Our topic is periodontal pocket. First, we will see what is a gingival sulcus. It is a V-shaped shallow crevice or space around the tooth, bounded by the surface of tooth on one side and the inner lining of the gingival margin on the other side. This V-shaped sulcus. In normal condition, it is about 2 to 3 millimeter. Now, what is a periodontal pocket? A pathologically deepened gingival sulcus is known as a periodontal pocket. So, when the gingival sulcus depth is more than or beyond 3 millimeter, it is a periodontal pocket. It is one of the most important clinical feature of periodontal disease. Now, the deepening of the gingival sulcus may occur by the coronal movement of the gingival margin, as we can see in this diagram, or it can be due to the apical displacement of the gingival attachment, or it can be a combination of both of these conditions. Now, how can you classify the periodontal pockets based on these headings, which we will see in detail. First is depending upon the morphology. It can be a gingival pocket or a periodontal pocket. Gingival pocket is also known as pseudo pocket. Why? Because here the pocket depth increases not because of the attachment loss or periodontal tissue loss, but because of the enlargement of the gingiva, and hence it is known as a pseudo pocket. We can clearly see in this diagram. So this is another diagram of a gingival pocket. You can see in periodontal pocket, it is of two types, supra-bony and infra-bony. In supra-bony pocket, the base of the sulcus is above the crest of the alveolar bone. In infra-bony pocket, the base of the sulcus is below the crest of the alveolar bone. Hence, supra-bony pocket is also known as supracrestal or supraalveolar. Infra-bony pocket is also known as subcrestal or intraalveolar. Now, what are the other differences between these two? The pattern of bone destruction in supra-bony pocket is horizontal, whereas in infra-bony pocket it is vertical. The interproximally, the transeptal fibers are arranged horizontally for a supra-bony pocket, whereas it is oblique for an infra-bony pocket. On the facial and lingual surfaces, for a supra-bony pocket, the periodontal fibers are horizontal and oblique in course, whereas infra-bony it has an angular pattern. Now, the second classification is based on the number of tooth surfaces involved. So accordingly, it can be simple pocket, compound pocket and complex pocket. In simple pocket, only one tooth surface is involved. In compound pocket, more than one surface may be involved. For example, maybe the buccal or the mesial side is involved, or maybe the buccal, mesial or a lingual side may be involved. The third one, in complex pocket, the orifice or opening of the periodontal pocket is on one surface, but the base of the sulcus, base of this pocket may be in some other surface. Maybe say, example, it is the orifice is in mesial surface of a tooth, but it may have its the base of the pocket may be on the distal surface. It may, from the mesial surface, it may go on the through the buccal surface till the distal surface. The third classification is depending upon the disease activity. It can be active pocket or inactive pocket. Next classification based on the nature of soft tissue involved. It can be edematous or it can be fibrotic. Now, what are the complaints of a patient with periodontal pocket? The patient may have localized pain or sensation to pressure in the gingiva after eating, which gradually diminishes. Then foul taste in the localized areas where periodontal pockets are found. Then radiating pain deep in the bone. Sensitivity to heat and cold is also found. Then tooth pain may be there in the absence of caries. So what are the clinical signs we can see? There will be gingival bleeding. The gingiva has a bluish thickened appearance from the gingival margin till the alveolar mucosa. And it also has a shiny and discolored puffy appearance. The tooth will be mobile. There will be diastema formation. Also the break in the facial and lingual continuity of the inner dental gingival region. Now, how can we correlate the clinical features and histopathological features? The reason for the bluish red color of the gingiva is due to vasodilatation and stagnation of blood in the blood vessels of the gingiva. It will be flaccid because of destruction of the gingival fibers and surrounding tissues. The reason for the smooth shiny surface is because of atrophy of the epithelium and edema. The pitting on pressure is due to edema and degeneration of the epithelium. The fibrotic nature, when the fibrotic nature dominate, it will have a pink and firm appearance. Consistency will be pink in color and a firm in consistency. The reason for the bleeding on probing is increased blood flow, degenerated and thinning of the epithelium. When we insert the probe, periodontal probe, the patient will have pain. The reason is because the pocket epithelium is ulcerated. When there is suppurative inflammation of the inner wall, there will be pus discharge when we apply digital pressure. Let's see what are the contents of a pocket. There will be debris, remnants of food, GCF or gingival clavicular fluid, salivary mucin, microorganism will be there, the enzymes, endotoxins and metabolic products of the microorganism. There will be desquamated epithelial cells, leukocytes or WBC, plaque covered calculus. Then the purulent exudate will contain living degenerated and necrotic WBCs, living and dead bacteria, serum and few amount of fibrin. What is the significance of this pus formation? Although it is a most common feature of periodontitis, it is only a secondary sign. It reflects only the nature of inflammatory changes in the pocket wall. It is not an indicator, the most important point is here that it is not an indicator of the depth of the pocket or severity of periodontal destruction. Why? Because maybe a shallow pocket may have excessive amount of pus formation, whereas a deep pocket may have little or no pus formation. So that is the significance of pus formation. How can we locate a periodontal pocket? We can use a periodontal probe for measuring. So there are two different pocket depths. One is the biological or histological depth, which is the distance between the gingival margin and base of the pocket. Clinical or probing depth is the distance from the gingival margin to which the probe penetrates deep into the pocket. So, from the gingival margin to the base of the pocket is the histological depth. In a normal sulcus, the probe can extend to about 1/3 to 1/2 the length of the junctional epithelium, as we can see in the first diagram. Whereas in a periodontal pocket, because of the inflammatory nature, the probe can, with the same probing force, the periodontal probe can penetrate beyond the apical end of this junctional epithelium, and it may extend beyond the cemento-enamel junction. So, the probing depth varies with the probing force applied. So, about a 75 Newton or 25 gram probing force is considered to be well tolerated and accurate for measuring the pocket depth. Now, while checking the periodontal pocket, oblique positioning of the probe. The oblique positioning of the probe help us to determine the interdental crater compared to the vertical insertion of the probe. It is clearly visible from this diagram. The process of measuring the pocket around a tooth to explore the pocket is known as walking of the probe. Let's see what is the pathogenesis or what is the reason for formation of the periodontal pocket. The bacterial challenge or plaque leads to inflammation of the gingiva. As a result, the inflammatory cells secrete matrix metalloproteases or MMPs. Also, the fibroblast phagocytose the collagen fibers. As a result of these two reasons, the collagen fibers are destroyed. Because of that, the apical cells of the junctional epithelium, they proliferate and they move down along the root surface. Because the underlying connective tissue is destroyed, the junctional epithelial cells will try to move along the root surface. Also, the volume of the neutrophils, they will increase. They may increase up to 60% increase in the neutrophil. Because of these two reasons, the coronal attachment of the junctional epithelium, they detaches from the root surface and they come down. This will result in pocket formation. Let's see the histopathology of the pocket wall or soft tissue wall or lateral wall. So the vascular changes involve proliferation of the blood vessels. Blood vessels are dilated and engorged. There will be varying degree of degeneration of the connective tissue also. In some areas, the connective tissue also shows proliferation of endothelial cells, newly formed capillaries, fibroblasts, collagen fibers, etc. What are the changes in the connective tissue? It will be edematous and there will be a dense infiltrate of plasma cell, lymphocytes and PMNs. Also, single or multiple necrotic foci will also be seen. Then, the epithelium undergo severe degeneration in the lateral pocket wall. There will be epithelial projections, that is dense infiltrate of leukocytes and also fluid from the inflamed connective tissue. The epithelium undergo degeneration and necrosis, leading to the ulceration of the lateral wall, exposure of the connective tissue and suppuration. Now, the microtopography of a soft tissue wall of pocket show the following areas in this order. There will be an area of relative quiescence, bacterial accumulation, emergence of leukocytes, area of leukocyte bacteria interaction, then area of intense epithelial desquamation, area of ulceration and finally area of hemorrhage. Now, what are the changes on the root surface wall of a periodontal pocket? As the pocket deepens, the collagen fibers in the cementum are destroyed. As a result, the collagen becomes necrotic and clinically it is very soft. It will act as a reservoir for the bacteria. So, the area of necrotic cementum is separated from the tooth by masses of bacteria. What are the other structural changes in the cementum? There will be presence of pathological granules, area of increased mineralization and also areas of decreased mineralization. The chemical composition of the cementum also changes. There will be an increase in the content of fluoride, calcium, phosphate, etc. The cytotoxic changes include bacterial endotoxins. Also, the bacteria penetrate into the cemento-dentinal junction. So, what are pathological granules found on the cementum? They are areas of collagen destruction or areas where collagen fibrils have not been fully mineralized. So when we do the root planing, these areas of cementum get removed. The necrotic cementum get removed, thereby exposing the underlying dendri. This will lead to sensitivity for the patient. Now, how is the tooth wall of a periodontal pocket? So there will be a layer of calculus which is covered by attached plaque, followed by a layer of unattached plaque. So these are the contents in the pocket. Then we have the junctional epithelium, partially lysed collagen fibers below that, and then intact collagen fibers beneath that. This is the tooth wall of a periodontal pocket. Now, how is the disease activity? It is not always continuous. There will be periods of activity followed by periods of remission or rest. Also, the periodontal destruction is site specific. Maybe the destruction is active in a few teeth at a time, or some teeth, surfaces of a given teeth itself. Let's see what is the relationship of periodontal pocket to attachment loss and bone loss. The severity of bone loss and attachment loss is not always related with the pocket depth. So the pocket depth has not always, it is not related to the severity of bone loss and attachment loss. Let's come to the last part of this periodontal pocket chapter. The first, that is treatment. First, we have to educate and motivate the patient to maintain the oral hygiene properly. We have to first remove the plaque and calculus by cleaning and root planing. Do gingival curettage wherever required. If periodontal surgical procedures are required, that should be done. So the treatment depends upon the type of pocket. For a gingival pocket, after scaling and root planing, we have to reevaluate the patient, check about how he or she is maintaining the oral hygiene. If pocket persists, we can go for a gingivectomy or gingivoplasty. For a true pocket or periodontal pocket, scaling and root planing first, followed by reevaluation and maintenance. Then, if required, the pocket wall should be removed. In case of a supra-bony teeth involving an anterior tooth, first scaling and root planing, maintenance phase, then pockets persist, we can go for a curettage. Then in case of moderate to severe pockets, flap surgery can be done using clavicular incision. Supra-bony pockets on posterior teeth, where the pockets persist after scaling and root planing, and if in areas there it is like inaccessible, we can go for a flap surgery. Similarly, for an infra-bony pocket also, we can go for new attachment procedures. Thank you.